So our next speaker is Brent Allan. Brent Allan is the Executive Director or Executive Officer of Living Positive Victoria and has been working in the community response to HIV/AIDS since the early 1990s, both in Australia and abroad, i.e. Canada. He has qualifications in health education, business and community services management, as well as public and social health experience at all levels of government, including local, state, federal, and internationally with the UNDP. As a gay man living with HIV for the past 16 years, he's been active in efforts to build the capacity of people living with HIV through advocacy, education, and representation, and has been the past Vice President of the National Association of People Living with HIV, convener of the International Think Tank on Gay Men's Health, and most recently the local co-chair for the community program for the International AIDS Society Conference in July 2014. He's a passionate advocate for community and consumer representation in health service policy, programming, and evaluation. Please join me in welcoming Brent.
Hey everyone. You'll forgive me, I don't qualify myself as a researcher, but and this is the launch of this data and this research from Australia, so you're the first to see it. I'd like to thank the people living with HIV who participated in the survey, my colleagues Ian and Allan from Deakin University. This is really important. I figured this out. I should have probably presented this yesterday about what the Australian situation is like in relation to HIV. It is considerably smaller than the epidemic here in Canada. It is considerably more homogeneous. We have an older median age of infection, and we have relatively high levels of treatment access and adherence. It is really variable. So it is a slightly different epidemic. It's a very gay epidemic. It's a very white epidemic. We don't have much of an epidemic amongst injection drug users, sex workers, or our Indigenous populations. As was talked about this morning, definitions on health literacy are incredibly important, and we follow, in our partnership with Deakin, very much the WHO's definition. And in particular, I want to highlight the aspects of the social or the contextual aspects of health literacy and how important that is, especially in terms of working in the community sector and understanding the influence and the dynamics of the relationship between people, be they friends or family, but also sort of social circumstance situations. We used, in terms of this study, the methodology is the Health Literacy Questionnaire. It has 9 different scales on it, 44 different items, where we're investigating those 9 areas or domains, from feeling understood and supported by healthcare providers, having sufficient information, actively managing, social support, appraisal of the information, the ability to actively engage, to navigate, to find the information, and then understand it well enough to know what to do with it. The Health Literacy Questionnaire has been translated into multiple languages around the world, and I think it's in use in 40 some odd different countries. This is a little bit more about the tool. As I said, 44 items, 11 relevant demographic items are through it. In terms of how we use the survey tool, we recruited through our membership base, which is several hundred people, and through other peer support services, both using online and paper versions. And then in terms of doing the actual analysis, it's constructed mostly on a cluster analysis that groups together like people from unlike people. We've identified 7 clusters in the sample, and we've described them across the 9 domains. I'm going to talk about 4 of the archetypes that we've created from the sample: the Michaels, the Pauls, the Andrews, and the Jordans. This is what the data looks like. The red areas are areas that are saying there's concern and there's low health literacy. The high green areas are areas where there is strong health literacy. You can see the Andrews are described there as cluster number 6. And we didn't describe cluster number 4, but you can see that cluster number 4 is showing the lowest levels of health literacy across the 9 domains. So why are we using the HLQ? We're interested in the HLQ because of Ophelia. In Australia, our national HIV and AIDS, our national strategy on HIV has for the first time identified health literacy as an essential priority aspect in responding to HIV, which is fantastic, because that means we have now the permission in the Amparmata to actually do health literacy research and health literacy testing, health literacy training. In Victoria, so in the state that I live in Melbourne, health literacy was identified before the creation of the National HIV Strategy as a key priority policy plank for the state of Victoria. And they have been running this Ophelia program, which stands for Optimizing Health Literacy and Access to Health Information and Services. It uses a multidimensional tool to identify health literacy, and in a co-creation model, helps us, from a service point of view, actually do the work, as I try to draw up my picture. So what do we mean by a multidimensional tool? This is how we ascribe each of the archetypes that we talk about, and we'll go into those in a second. Those are as I said, the 9 domains, and this is what it looks like when we do the description on them. So we will score them anywhere from very low to very high, both inside themselves, inside the archetypes, but also increasingly inside the HLQ larger database amongst different disease cohorts. So what does it mean in practice? So this is how Ophelia works. We identify, using the HLQ, the health literacy strengths and limitations of a local community. In this case, gay men living with HIV. In phase 2, we co-create health literacy interventions using a study, plan, do, act cycle. And we do this in collaboration with the researchers. So this is not done by ourselves. Those of us who are working in the field or doing management are deeply embedded and deeply co-creative with the researchers on this project. And then we trial and test again. And one of the things we trial and test to do in phase 3 is whether or not some of the interventions work across different health domains. There's some programs at the moment going on with RDNS, which stands for the Royal District Nursing Society, and some of their interventions we're finding have great utility for people living with HIV. So a bit more about the sample description of our study, 148 respondents. As I said, this is the first time we've been able to use health literacy, I wouldn't say officially, but with the absolute imperative as a health priority, so it means it gets funding, which has been fantastic. Our national strategy, our latest one, was only released at the International AIDS Conference, so it's fantastic. We're now able to invest in this way. This is a bit about what they look like, and I did want to say, yes, they're very white, but our epidemic is very white. This is what Michael looks like. They're the largest group inside the sample. They're average educated white collar managers. They're a little bit older. They're very community attached. They've been diagnosed pre-heart, and they have incredibly high compliance and adherence levels. But as you can see, they're scoring only moderately high in terms of social support for health. This is the PALs. This is what the PALs look like. They're 19% of the sample, mid-40s. 2/3 are university educated. They're less community attached, and they've been diagnosed post-heart as opposed to the Michaels who were diagnosed pre-heart. But again, showing low levels in terms of social support for health and lower levels across a variety of the other domains as well. This is the Andrews. These are very Australian, these Andrews. they're very strongly Australian born. They finished high school, mid-40s, diagnosed post-heart. They do have some non-treaters. We had a very difficult time. We tried our best to try to get non-treaters, and we just couldn't find them. Which is weird because in the first slide I showed you, we have something like, between 50 to 70% uptake, but we're finding in this study that it's up around 90%. But again, low scores on social support for health. And finally, we have the Jordans. These are the younger guys. They live in lower sociodemographic areas. Oh, nice spelling mistake, Brent. Low levels of education and low levels of community attachment. And again, low levels of social support for health. So some of the limitations of this study, the respondents appear to be highly educated and appear to be more highly educated than our large survey samples of people living with HIV. We have a cohort study that's been going for a number of years called the Future Study, and this sample seems to be much more educated than that. They seem to be relatively well connected to community services, although differentially. And again, I said this, only very small numbers on ARVs, not on ARVs, I mean. And I think we are underestimating, in some cases, the health literacy issues. But again, this is our first go at health literacy in this sample. Overall, the clusters have low levels of social support for health. There's a clear link between those not finishing high school and lower health literacy, and the non-Australian born men have lower health literacy. And I'll show you this. We'll go through these quickly. I just wanted to talk a little bit about what we mean by social support for health, because it shows up across all of the archetypes. And this is what we mean, that they appear to not have, or they probably have, but they're not utilizing the social support they could be in terms of increasing their health outcomes. And we talk about this in taking different forms, emotional, instrumental, and finally informational support to help people inside their social circles. This is some of the data around gay men with HIV and their low education levels. You can see that those who didn't finish high school are scoring lower across all of the domains. And these are the men who weren't Australian born, and again are showing lower levels of scores across all domains. So the next steps are to do more of this amongst specific minorities in Victoria, women and migrant populations in particular. We want to explore some of the variations around the social support for health. We certainly are interested in looking at using the HLQ internationally and comparatively amongst HIV-positive populations, and to explore interventions in testing. What we're going to be doing is expanding some of the social support programs, developing health knowledge application programs such as health coaches, and developing guidelines which will help people living with HIV be able to better critique and judge the quality of health information that they can access. Thanks.